You guys hear me?
Oh, yes.
Great. All right, thanks. When Kelly brought the topics to us in the EP department, one of the topics that came up was how do we approach patients that come to your office clinic with palpitations, or as my mentor used to call them, Palpitations. This is one of the most common topics that people come, complaints that people come to the primary care and or the cardiology clinic office with, and there's highly heterogeneous patient population, highly varied etiologies for this. So I think it's an important thing to review because it can be extremely frustrating taking care of these patients at times. So there actually is not a very concrete scientific definition of palpitations or palpitations. They're a perceptible, unpleasant, forcible pulsation or movement in the chest or adjacent areas. It's usually with an increase in frequency or force, and it can be with or without an irregularity to the rhythm. What causes palpitations? It's a lot of big words on this slide. Basically, the bottom line is it's not very well understood. There's different afferent sensory pathways that connect to higher level cognitive processing areas that bring some conscious attention to the patient that they're having something wrong in their chest. Possible sensory receptors have been implicated or in the myocardium, the pericardium, or peripheral mechanoreceptors. Brain centers at the subcortical region and the base of the frontal lobes have also been implicated as being part of this pathway, but it's really not well understood. There's various mechanisms that cause palpitations. They can be from contractions of the heart that are too fast, too slow, or irregular. Oftentimes these are due to systemic illnesses, systemic diseases, or medication-induced palpitations. They can feel like very intense contractions and be due to anomalous movements in the chest or the heart, often in cases where people have structural heart disease, or they can also be anomalies in the subjective perception of what's happening in the heart, in the heartbeat, or psychosomatic etiologies. As I mentioned before, it's one of the most common outpatient complaints in patients presenting to primary care providers and cardiologists. In one study of 500 patients presenting with cardiac complaints, it was 16% of them. The patients that present will use terminology such as a rapid fluttering in their chest, a flopping in their chest, or a pounding in the neck. What actually causes the palpitations is also highly varied. The number one cause is arrhythmias. If you break these down, many of them are AFib and flutter, as Dr. Patel was talking about. 10% are SVTs, the minority are ventricular origin. The second leading category, kind of like Family Feud, is psychosomatic, mainly panic or anxiety disorders. Some of the patients, their symptoms are due to medications, often illicit drugs or stimulants. And detailed history there is certainly important. Systemic causes like fever, barotoxicosis, etc., can cause palpitations. Structural heart disease is actually a minority of these causes. Patients with ischemic heart disease or shunts, patients with severe valvular abnormalities, which we'll touch upon. There's also a large category where you won't find a cause, often like syncope evaluations. A specific cause will be found for their symptoms. These are charts, but I won't go through in full detail for sake of time. You can use these references as far as what the causes of specific etiologies are. Sometimes you can have a malfunction of the pacemaker at the end of life, which will cause sensation of palpitations as it goes into conservation mode. It only paces in the bottom chamber, causes AV dysynchrony. You can have sensation of palpitations due to intermittent heart block. Certainly there's a lot of psychiatric illness that can cause the perception of palpitations, as we've all seen. Certain medications, particularly sympathomimetics, vasodilators, both initiation and withdrawal of beta blockers can cause sensation of palpitations. Illicit drugs or certain habits, and stress and exercise can also cause palpitations. There's a list of metabolic disorders and high output states that also can cause this sensation of palpitations. So I want to touch upon some of the specific arrhythmias that can cause palpitations. Number one category, certainly premature beats are the most common type, premature atrial contractions or ventricular contractions. Sinus arrhythmias, just variations in the sinus rhythm, specific types of SVT like fib, flutter, or specific mechanisms of SVT. Idiopathic ventricular arrhythmias coming from the left or right ventricular outflow tract. And certainly they could be also caused by life-threatening rhythm problems like monomorphic or polymorphic ventricular tachycardia, torsade de pointe, or ventricular fibrillation. A large list of psychosomatic disorders as well, as I mentioned before, primarily anxiety and panic, depression. The typical manifestation for these patients is just a fast normal rhythm, sinus tachycardia. These underlying states can also modify the patient's subjective perception of a heartbeat that is otherwise normal, presents with minimal irregularities. This is a key slide that I want to spend a minute or two on. The problem with this situation is that there's a huge overlap between patients that have underlying psychiatric disorder or psychosomatic behavior and have arrhythmias. And the reason is that cardiac arrhythmias and psychosomatic disorders are certainly not mutually exclusive. You should consider the etiology psychiatric in origin only if the patient meets clinical criteria for that psychiatric diagnosis and no other potential cause has been identified. And ambulatory monitoring, et cetera, has shown that their symptoms, when they're having symptoms, are not due to arrhythmic etiology. These patients can have hyperactivation of their adrenergic nervous system that's associated with anxiety and actually make them more arrhythmogenic. One study, which is listed at the bottom here, Lesmeyer et al. In 1997, showed that patients that had SVT, 2/3 of those patients were actually misdiagnosed as having an underlying panic disorder when they were actually just having SVT episodes. And most of those same patients were cured, quote unquote, cured of the psychiatric illness by catheter ablation under SVT. So it's important to tease that out. You know, it's easy for us to label our patients as being crazy when they come in and say they have these symptoms. We don't find anything initially, but that's a lot to do with potentially the yield of our monitors or testing. The types of palpitations that we'll see with illicit drugs or recreational drugs are primarily sinus tachycardia. List of drugs that can cause it here. I won't go through each one in detail. Some drugs at the bottom that are listed, you need to be aware that belong to QT, a lot of psychiatric drugs, methadone, SSRIs, et cetera, antibiotics, et cetera, can belong to QT and cause problems with propensity for ventricular arrhythmias. A list of systemic causes of palpitations are here, specifically hypovolemia, anemia, fever, pregnancy state, thyroid disorders. Rarely you might see a theo. And we'll go through some of these as well. The heart disease that can cause the sensation of palpitations. It's usually in the absence of actual rhythm disturbances. The patient feels this sense of pulsation where their heart is whooshing or having a very strong beat. May feel a clicking sensation if they have mitral valve prolapse. Severe MR or AI can cause the sensation of a very strong pulsation, but there actually is not truly an arrhythmia. So the approach to the patient when they present to you, I think, is twofold. One is the cause of the palpitation something life-threatening? That's what you want to determine. Is it something we really need to worry about, that I need to treat or refer? Or is it something that I can just reassure the patient? And overall, what are we going to do at the end of the day to make our patients feel better and feel like we've taken care of them? So I think, like with anything else, the history is the key. You need to know what the circumstances that are causing the palpitations are arising in. A detailed history is where the money is. Is it associated with anxiety and panic? Once again, even though that might be the case, many of these patients still could have a true arrhythmia. Is it associated with stress? You can have stress-induced arrhythmias, like catecholinergic polymorphic VT that can be fatal, but you can have benign arrhythmias as well. These are just clues that help you along the diagnostic pathway to determining what the arrhythmia is. Is associated with positional change. Oftentimes when you change position, you might change vagal tone, cause PACs or Tbcs that might induce a specific type of SVT like AV node or atrial tachycardia. Is arrhythmia associated with syncope, near syncope, lightheadedness? This is very critical because that's implying there's some sort of hemodynamic compromise with the arrhythmia or the palpitation. And then you should have a higher suspicion for a ventricular arrhythmia in that situation. So as you go through the detailed history, you want to figure out, when did these arrhythmias first start? That'll give you a clue as well. Did it start when they were a child in PE class? That usually tell you that maybe this is a circuit type rhythm or an inherited pathway perhaps. What is the onset? Is it happening at rest? Is it happening during stress? Is it happening during sleep? What is the duration of the arrhythmia? Is it transient, a few seconds? Is it minutes, hours? What are the symptoms of it? Is it causing lightheadedness, dizziness, or very minimal symptoms? How does it terminate? Many people that have, for example, SVT will teach themselves vagal maneuvers. Just over the course of time, they'll say, oh, every time I cough, it goes away. Every time I bear down, it goes away. That gives you obviously some clues as to what it might be. Having the patient tap out the rhythm on the desk in the clinic, they can tap it out, and you can sometimes figure out, is it a Tbc or maybe it's AFib? They're tapping it out irregularly. What kind of personal habits do they have? Obviously, younger patients, you want their parents out of the room if you can. Do they have a known or unknown psychiatric disorder? This is a chart from the European guidelines to palpitations that I borrowed, and basically it lists each type of palpitation, the type of palpitations they have, and subjective description. This is obviously not clear cut. There's a lot of overlap, but people that have, for example, PACs and PVCs, they'll typically describe that they're missing a beat or skipping a beat. They typically don't actually feel the PVC, but it's the subsequent beat that they feel. The increased potential energy, if you will, with the next beat, because of increased diastolic filling time, makes the next beat feel harder, stronger. The heartbeat's often described as being irregular, but with many periods of regular heartbeat. The onset is sudden, and there's not much that really triggers most of these. People that have, SVTs or atrial tachycardia will describe fluttering or beating wings in their chest. It can be both regular or irregular, with marked acceleration from onset. Often occurs during exercise or during the cool-down phase. You may describe shortness of breath or chest pain with it. People that have anxiety-related sinus tachycardia will typically say that it's very regular, that it's just slightly faster than the normal rhythm, with the gradual onset and offset occurring in times of stress. They'll describe a tingling sensation perhaps, or a lump in their throat. This pulsation type of palpitation refers to people that have often structural heart disease or anemia or fever, where they don't truly have an arrhythmia, but they're describing a strong, steady, regular sensation in their chest that's very gradual and maybe worse with physical effort, often with aortic regurgitation or microregurgitation. These are another chart for the types of symptoms people will report with specific types of SVTs and VT. So with AVNRT, the most common type of SVT or accessory pathway mediated tachycardia, sudden onset, usually very regular with a very fast heart rate. It may occur during exercise or postural changes. They often describe urinating more frequently. This is usually due to increase in atrial natriuretic peptide initiation. It's also common with AFib. They'll describe with vagal maneuvers, sometimes as I mentioned before, that they've taught themselves it works. With AFib, obviously you have a regular rhythm occurring during exercise or maybe after a large meal, the vagally induced AFib, or the excessive alcohol intake. Vagal maneuvers typically only cause a transient reduction in the heart rate. Both ATAC and atrial flutter will be more regular typically, maybe some periods of irregularity. They'll often feel shorter breath. With VT, the key thing here is usually hemodynamic impairment, sometimes with physical effort. So unfortunately, all of these individually, these types of symptoms, you can't hang your head on. There's not one specific thing the patient's going to tell you that you're going to say, I got the diagnosis. The utility of these features are generally poorer to diagnose the arrhythmia. People that describe visible neck pulsations or like the frog sign, where they have a frog in their throat, that sometimes gives you a clue that they might have a specific type of SVT, AVNRT, where the atria are contracting against a closed tricuspid mitral valve, but the likelihood ratio is only 2.7 for that. Typically, event duration greater than 5 minutes is visible neck pulsations that they'll tell you about if you ask, occurring at work or during sleep, makes it more likely that it's a true arrhythmia rather than something that's not going to be arrhythmic in etiology. So the next step of the evaluation beyond the history is a physical. Unfortunately, we rarely have the opportunity to examine someone when they're having an arrhythmia. You might get lucky at times. But what you can do when you're doing your physical exam is look for other signs. Do they have a click of mitral valve prolapse? Do they have dynamic systolic murmur of hypertrophic cardiomyopathy? Do you hear regularly a regular rhythm on your routine physical and indicate probable AFib? Do they have any evidence of a cardiomyopathy or valvular heart disease or congenital abnormalities? The next evaluation typically involves a 12-lead EKG. We'll go over a few cases here. There's various patterns we see here. For the sake of time, I won't go through all of them. So I just want to go through a few of these slides here. So can anyone tell me what we're looking at here? You had a patient that came in complaining of palpitations, you did a CKG. Right, so ventricular bigeminy. So you see PVCs occurring every other beat, sinus beat, PVC, sinus beat, PVC. This is of a left bundle pattern with an inferior axis, probably from the right ventricular outflow tract. So PVCs are very common. They occur in both healthy patients and patients with structural heart disease. If they occur in isolation, they're more likely to be benign compared to multifocal PVCs or non-sustained VT. The key thing is to determine if structural heart disease underlying, because there's a major difference between people that have PVCs that don't have structural heart disease and people that have PVCs that have structural heart disease or especially ischemic heart disease. Their risk is significantly different. The main issue, if they do have structural heart disease, is to treat that underlying condition. Oftentimes, the ventricular will also be treated. You have patients that have PVCs that are not related to structural heart disease that are very symptomatic. You may want to try treating them with beta blockers, calcium channel blockers, occasional antiarrhythmics like flecainide or early amiodarone. If that improves their quality of life, you may continue medications. If medications are not effective, you want to consider ablation of the PVC. Over the last 10 years, Tbc Associated Cardiomyopathy has been recognized. I think 2006 was the first time this was well described. The cutoff seems to be around 25% PVC burden, although we see exceptions where people have less than 25% of their PVCs causing a cardiomyopathy. But certainly if you get a Holter monitor and you're seeing 20, 30,000 PVCs on it, you need to be worried about the development of a PVC-induced cardiomyopathy. And whether they're symptomatic or not, that patient should be further evaluated. The prognosis of that cardiomyopathy is actually very good in patients that have no structural heart disease. So this is actually a patient I saw yesterday in clinic. I thought it was kind of salient to bring up. Anyone want to venture a guess as to what's going on here? So the computer read this as AFib, and the patient was started on warfarin and referred to me for evaluation of AFib. But I think if you look closely, you can see there's P waves before every QRS, PAC with aberrancy here, some different PACs over here. So this is just frequent PAC, sometimes with aberrant conduction, not AFib. Initial glance at it, sure, it looks like AFib. It's irregularly irregular. There's a lot of baseline artifact there. You can certainly get fooled. So these are PACs. Symptomatic PACs are common. They occur primarily in patients with both with and without structural heart disease. They're typically benign and don't need any treatment. Certainly they've been mistaken on physical exam and by computer EKG interpretation for AFib. It can also be a precursor for AFib in some patients. Typical treatment is behavior modification, sometimes beta blockers for patients that are symptomatic. This is a pattern you might see in the clinic as well. Short PR interval, slurred upstroke. This is WPW. Patients could also present with SVT with this. So supraventricular tachycardia typically occurs with patterns of recurring episodes increasing in frequency and severity, typically not associated with structural heart disease, except for rare exceptions like Epstein's anomaly or hypertrophic cardiomyopathy. You may have narrow or wide complex SVT. It may be difficult to distinguish between SVT when it is wide. I think the key take-home point is that if you have a patient that has structural heart disease, I would presume it's VT until otherwise proven and treat it that way. As we mentioned before, vagal maneuvers often will be effective. Beta blockers, calcium channel blockers, sometimes antiarrhythmic drugs are used. Patients end up in the ER, they're often treated with IV adenosine. Catheter ablation is certainly highly effective and is often recommended as first-line therapy, as most of these patients don't want to take medications for the rest of their life, or it's not well tolerated or effective. This, I think Darrell's gone over quite a bit. It's AFib. Won't spend too much time on this. Certainly, it's very important to diagnose this in patients in the primary care setting because of two reasons: stroke risk, and if you leave AFib unabated, it can cause tachycardia-mediated cardiomyopathy. This is a patient that I saw in fellowship who had prolonged QT interval. You can see over here, QT is very prolonged and is having short salvos of polymorphic VT. This was induced by methadone. So there are certain patterns in the EKG you might see when the patient is symptomatic and not symptomatic that are important as well. They're listed here. So two things I want to mention. If you have Q waves on your EKG, you certainly want to worry that the patient has a substrate for ventricular tachycardia. If they're describing symptomatic palpitations or lightheadedness, you need to presume they might be having VT. Certainly if they have a long QT, described as over 460 milliseconds in females or 440 in males, that's a QTC. You just should suspect long QT syndrome and look carefully at their medications, their electrolytes, etc. So the diagnostic yield of the history of the exam and the EKG is only 1/3. Further diagnostic testing is required for other patients. You want to rule out structural heart disease, typically with an echo. If they have suspicion for coronary disease, a stress test or cardiac cath may be indicated. If they have a suspicion for ARVD or sarcoid, MRI would be indicated. I just want to spend a couple minutes, running out of time here, but on EKG monitoring. So you guys order a lot of Holters, a lot of event monitors. The yield for these are okay. It really depends on the symptoms of the patients and if they're having symptoms while they're wearing the monitor. So if you order a Holter monitor and it comes back normal, the patient didn't have any symptoms while they were wearing it, it was kind of worthless. It doesn't exclude an arrhythmic etiology. The yield is really dependent upon whether they're having symptoms or not. If they have a clinically significant arrhythmia, but they're not symptomatic during that, it doesn't prove that their palpitations were due to that. If it's concerning, you need to further evaluate it. But if they had 3 beats of SVT, they mean nothing. It may suggest a probable diagnosis if it's very frequent, as some patients are not reliable or may not fill out their diary. So I think that broadly, when you order a monitor, it's helpful on a binary level. If they have symptoms and there's no arrhythmia there, that tells you something, that their symptoms are probably not related to an arrhythmia. And if they're having symptoms and there's definitely an arrhythmia there, that tells you something as well. But everything else is the gray zone. If patients have very infrequent arrhythmias, like every few months or every several months, but you're concerned about them, you may want to consider an implantable loop recorder. Some of the limitations of EKG monitoring is it's difficult to arrive at a precise diagnosis. You might see some sort of narrow complex SVT or tachycardia, but you can't tell the mechanism. The clinical context is critical, like anything else. Is it happening when they're symptomatic? Is it happening when they're awake or asleep? If you see a 3-second, 4-second pause when someone's sleeping, and you order it for syncope, it doesn't tell you that that's what's causing the syncope. It may indicate some degree of sinus node dysfunction, but they were sleeping, so maybe they were apneic, or maybe they had high vagal tone at that time. This is a chart I won't go through in detail because of time, but basically it shows the differences, advantages, disadvantages, Holter events, and ILRs, and when to use them. So what kind of therapy are we talking about? It's basically directed to the underlying cause. Many patients you can reassure. In the case of a benign etiology, some patients you might just recommend some lifestyle modification. For patients that have underlying psychiatric illness, that should be treated, or they should be referred for counseling. If a specific arrhythmia is found, trial of medication certainly. For specific arrhythmias, ablation should be considered, and certainly if their palpitations are due to intermittent high degree AV block or malignant arrhythmias, a pacemaker or defibrillator may be indicated. This is just for reference. Many patients have inappropriate sinus tachycardia. This is a diagnosis of exclusion. You have to rule out a lot of systemic causes first. There are therapies which are usually beta blockers or calcium channel blockers. There's a new drug that's now available for heart failure in the United States. It's been used in Europe, Ablation, which is a sinus node-specific suppressant that we hope to be able to use sometime in the future for this entity. Typically, ablation for inappropriate sinus tachycardia is not effective and may be dangerous. So the take-home points are palpitations are very common. It's a heterogeneous group of patients. The history is really where you're probably going to figure out the most of it. The EKG can give you clues as to what's going on, and ambulatory EKG monitoring, I think, with looking through the right lens of what you're actually evaluating, depending on whether they were symptomatic or not, the yield can be good up to the high 80s in some cases with event monitors and ILRs. The therapy should be directed to their underlying cause. And if there's any concern for patients that have any high-risk features, certainly they should be referred for further evaluation.
There.
I think they're all great references if you wanted to read more or look into the guidelines.